So we're in the research breakout session. Hopefully you're all in the right place. My name is Paige Krack. I am a quality improvement specialist with Cincinnati Children's, and our leaders for this session today will be Anita Krishnan from Children's National and Tjoeng from Seattle Children's. We would like the session to be interactive for this short amount of time, so we're hoping to hear from you. You are able to unmute, or you can use the chat box Zoom feature to talk as well. And with that, I'm going to turn it over to Lee to walk us through a few polling questions.
Hi, everyone. I'm Lee. I'm one of the cardiac intensivists at Seattle Children's Hospital and a member of the PC4 Collaborative. So I think initially what Dr. Krishnan and I wanted to do was get an idea for who we have joining our session for research. And so we'll start off with our first polling question, if you all would be able to participate in these. So the first question we wanted to know is who is in this breakout session with us? Cardiologists, intensivists, NPs or PAs, nurses, dietitians, social workers, trainees, parents, or anyone else who's been able to join us today. And let's see. Oh, this is great. So it looks like we've got a nice spread among the number of people and the types of people who are able to join us today. I see a lot of others that we maybe didn't capture when we did this. So if people want to just put in what other role they have in the networks in the chat box, that'd be nice just for us to share. But otherwise, we'll go on to our next polling question here. So if you are a clinician, we were curious how many years you've practiced. 0 to 5 years, 6 to 10 years, 11 to 15 years, or greater than 15 years. I'll answer that in the chat box. It looks like we have a pediatric clinical neuropsychologist, which is really great, especially seeing how little research has been done in that area after congenital heart surgery. And a lot of other researchers and marketers as well within the field, which is really cool to see. All right, so it looks like we also have a good spread here for people who are young and new in their career, which I think is really exciting and offers a great opportunity for fellows to work with young clinicians and for younger clinicians to kind of hopefully be able to network with people who have had even more experience in the field. And over a third of the people here have had more than 10 to 15 years of experience, which is really great. I think we have just another polling question to get to know you all better. And if you are a clinician or research, really anybody in this, we put clinician, but anyone who's in our group today, whether or not you have conducted health disparities research before, or if this is a relatively new topic that you all would like to dive into. So it looks like about a third of you all have done this type of research before, and for a majority of you, this is kind of a new field, which is really wonderful. I think that you all have been able to come to this webinar, and hopefully we can have some further discussions about where health disparities research is now and what we can do moving forward in order to level the playing field, so to speak. So I'm going to hand this back over to Anita Krishnan right now, just to kind of give an introduction to our breakout session and set the stage for further discussion with all of you.
I don't have the slides, Lee. Can you advance them, Paige? Okay, I'm not going to go through my slides again in the interest of time. I think we should just move on to our discussion. So you can go to the next slide. Keep going. So this is what the couple things I wanted to talk about are: one, what are the challenges to multi-center disparities research in CHD? Which data sets should we be using? There's so many different places that you can pull your data, but what I found in trying to do my study is that no one database had all of the data sets that I need, and we actually ended up going back and collecting a lot of it manually, and that's what I've seen in kind of other studies that try to link prenatal and postnatal data. It's difficult to accurately capture race and ethnicity data. We often found that some patients may not report it. And so then, you know, if you have a large number of patients with unreported data, it's difficult to do studies. And then there's lack of a single centralized mechanism to collect maternal and neonatal data, as well as deaths prior to surgery. So we can go to the next slide. So where do we go next? We know these disparities have been around for decades. Hopefully, if we have this conference again in 10 years, we won't be describing them, still describing them. So the next phase of research requires us to identify the specific mechanisms that are underlying these disparities and then transition to action-oriented trials. So I wanted to open it up to the group, and I think we're a small enough group that people can either unmute and share their thoughts, or you can make comments in the chat. Question one, if you've done research in this area, you know, what have you found to be a challenge?
It looks like there were about 35% that they've done some type of research. So surely someone has run into a challenge.
Is anyone able to just describe some of the studies that they've done in this area?
Hi, this is Karen Goldberg. I think one of the things that is a challenge sometimes with research when we're looking at race and ethnicity is knowing what is a reliable source for race and ethnicity. And when people, and it may be different depending on a question of neighborhood issue, you know, where self-identified race is probably the most meaningful versus a biologic issue where, you know, the genetics people might tell us differently. But I just think that that's an interesting issue when we think about race and ethnicity.
And in the work that you did, Karen, can you describe how you got the data and what you used it for?
Yeah, and when we've done studies at our own center, race and ethnicity is recorded in the medical record. It's usually reported by the family, although sometimes we think that it, in the earlier days especially, that, you know, just an admitting officer had guessed at what they thought was correct, maybe based on a last name or something, which we've had the information that we've had, I guess, in some of those earlier studies. But I recently did a study here with one of my colleagues who's a gastroenterologist, looking at just that issue with the accuracy with which race and ethnicity was reported using two different data sets, at least looking at the consistency from the medical record to another data set that had been collected for another reason. And we found, surprisingly, that it was not perfect, but very consistent between the two data sources. But just think it's something we always wonder about. What does race mean? What does ethnicity mean? In some research studies that are looking at both sociodemographic factors as well as biological factors.
And David Werho just asked, is there a universal or at least national standard for how to define and study race versus ethnicity in medical research? I find some studies will analyze Hispanic as a race while others do it as a separate ethnicity field. You know, our epidemiologist in my study, we definitely classified Hispanic as an ethnicity. And tried to use methodology similar to the census. but I'm certainly not the leading expert on it. So if there are others in the group that have had different experiences.
That's typically the model that, this is Lee, this is typically the model that we've used as well, is to use what the census identifies as different races and ethnicities. And typically I found that Hispanic is the most identified with as an ethnicity, and to classify it as such.
Within the cardiac networks that participate in this group, is there standard reporting of race and ethnicity, and do all of the networks do it the same way?
Since the CNOC registry was built as a module onto PC4, we are using for sure the same methodology as PC4, and PAC3, which seem to make sense to us. And as you said, ethnicity is separate from race for that in that model.
And so if an investigator was going to use either PC4 or PAC3, what percentage of patients would you say have race and ethnicity data reported?
I don't know the answer to that. David, do you know the answer to that?
I can answer that. The majority. It's not required, but a high percentage would have race and ethnicity.
That's great. So of our fellows in the group, who I think, are oftentimes the powerhouses of research, have you found any struggles to doing disparities research?
Speak a little bit to that. Hi, my name's Jen. I'm one of the fellows at Children's National, and I've been fortunate to get involved in some of the multi-center studies. And I think something that I've run into a little bit is understanding some of the legal agreements and issues creating like data use agreements between centers, just something that's not within my wheelhouse at all, but I've really had to learn a bit about. And so I think having a good support from the legal department at your institution has really been key and been helpful. And then I think another thing that I'm learning is that, a lot of times there's a lot of data out there, and as a fellow, it's important to narrow and kind of hone in on like one specific question or one small aspect, and to extrapolate data that's really just relevant to that question, rather than maybe perhaps getting overwhelmed by the breadth of data that's out there.
Yeah, and just to piggyback off that, I think one of the hardest things I had when I was starting out as a fellow was really understanding what databases were available to me and how they were different and which one to choose for the question I wanted to ask. And so one of the difficulties I found, and I'm curious to hear if other people have had the same experience, is that different data sets will collect different aspects that you could use for your disparities research. So for example, some might not collect socioeconomic status by zip code. Some might not collect insurance status, but they will have race and severity of illness scores that you need for the question that you want to answer. And so trying to find one data set that adequately has the variables needed to do a really solid disparities research project, I've found difficult, and I'm curious if other people have found similar issues.
I found that as well, Lee, in putting together my study. I began as a fellow and initially tried to go through STS and then considered going through PC4, but just finding one database that had every single piece of data was challenging. And so I think having investigators go back to their own databases is also really time consuming. So there's, hopefully a good way that we could leverage everybody's, or pull everyone's data together to avoid investigators doing more chart review. So we actually only have a couple minutes. The breakout session ended up pretty short, but if the group had to come up with priorities of what the next biggest steps would be in disparities research and CHD, does anyone have any thoughts? What would be the 1 or 2 priorities? Would it be surgical outcomes? Would it be improving prenatal detection? Lee, I found your work really interesting on CICU outcomes.
Thanks. So my health disparities research has been in looking at post-operative differences and care and seeing where along the spectrum we're able to intervene. We found that some of it at least happens to be severity of illness mediated, meaning that if we looked at preoperative or intraoperative factors, that potentially that could reduce disparities. There's a suggestion in the chat box about transitioning our adolescent population, which I think is a really important area of transitioning care.
This is Scott
go
from
ahead.
Colorado. There are a couple areas that I think are really difficult to study that I was wondering if anyone had suggestions. I think looking at intrinsic implicit bias and trying to develop a clinical outcome after an intervention, I think it's extremely difficult to do. I think you can do some of the implicit bias testings and see your scores before and after, but I was wondering if anyone's developed some sort of clinical outcome measure following interventions for bias. And then the other question I have is the issue of trust of the medical system in minority populations, especially African American population, and there's so many ways that the really justified mistrust they have impacts recruiting for research. We found with the teammate trial, which is the first clinical trial of maintenance immunosuppression in pediatric heart transplant patients, was having a difficult time recruiting African American patients, and I think that's a combination of implicit bias plus mistrust. So does anyone have any suggestions for trying to find endpoints to study those two issues?
I think it's hard to get at some of those issues quantitatively, even though we know inherently they contribute to some of the racial and health disparities. And as I've been thinking about that, especially implicit bias and variations in care after admissions to hospitals or entry into the healthcare system, is wondering if qualitative data and research has a bigger role in some of those areas. And I certainly have zero experience in that, but if other people have any suggestions or clinical outcomes to follow, that'd be great.
We're in the early stages of it at our hospital, but are doing kind of a hospital-wide education on implicit bias or in the early planning stages of it. So nothing now, but I would hope to have more information in a few months.
I hate to interrupt this great discussion, but we have to move on to our wrap-up section. Thank you, everyone, for a great discussion. I'm sure we'll be having many more as we go. And thank you to Anita and Lee for leading this discussion.